It seemed really appropriate to us to sort of do something, to have a discussion around COVID and the health service. And obviously we've got any number of fellows and alumni who are involved in the health service. I was particularly keen to do it, I have to say, because I also chair the Royal Brompton and Harefield hospitals, so which are specialist heart and lung hospitals. So I've been, very aware of the massive effects of COVID on the staff there, and the massive changes that we had to make. So it felt really important to me to share some of that. I'm really pleased to be joined by Rebecca Joyce, who is COO of Doncaster and Bassetlaw hospitals, who came through the NHS training course, which she recommends highly, but had a year off in Japan before she started. But since then, you must have done, what, 23 years, Becky? I think you've done a long stint.
Yeah, about 21 years, I think. Yeah.
So she's going to talk to us about the effect of dealing with coronavirus on her hospitals. And Dr. Aaron Dessar is a Fitz alum, originally law and a fellow in medical sciences. Not surprisingly, specialises in medical law and ethics. He's also Specialist Registrar at Addenbrooke in Anaesthesia and Intensive Care. And as I said, I know he's off to do Peterborough nights tonight and was last night. So all hands to the deck. So what I'm going to suggest is that I hand over first of all to Becky, and then I'll come to Aaron, and then I'll just say a little bit about Harefield and Brompton, and then we'll throw it open for questions and just conversation, frankly. Becky, over to you.
Thank you. So hello and welcome everyone. And really what I'm going to do in the next 10 minutes or so is just talk about my role as Chief Operating Officer at Doncaster and Bassetlaw hospitals in Yorkshire. We've got two main hospital sites, with both which have emergency departments, and then we've got a rehab hospital as well, the Mexborough Hospital. So I'm just going to talk about my role in terms of leadership through the pandemic. And I'm just going to start by sharing our experience in numbers. So Nicola, if you could just pop the first slide up, that would be great. So if you move on to the next slide. Thank you. So just if you can see this just gives a snapshot really of our experience as a hospital trust through this time. So as of today, we've had 2,928 COVID-19 inpatients. We've had 279 patients that we've cared for on our intensive care units. We've managed to successfully discharge over 2,000 patients and sadly had 749 deaths. And at our peak of COVID, we had 49% of our general beds occupied by COVID patients. And for us, that came in mid-November. So about 6 weeks before what's happening now in London and the southeast. And just to put in context also, of course, this has had a massive impact on our staff. So at the peak of our COVID occupancy, we had 15.5% of our staff absent, 10% for COVID related reasons, and the remaining third due to other regular issues. So really at the height of trying to manage the pandemic, we had a really high volume of staff from our frontline areas absent. I also just want to say up front that we've also had tragically 3 staff members die. Medit Atala, who's one of our care of the elderly consultants, Kevin Smith, a plaster technician, and also Lorraine Butterfield, who was a nurse in our emergency department. So really a really tragic and profound time for our organisation, as well as managing the impact on the local population. So the 3 graphs that you can see, the one on the top right, so we'll just wait till we get the slide. Yeah, brilliant. The one on the top right just shows you how we experienced the 2 waves. So we had the first wave in April, which had a big impact, but was not to the extent that we saw in the south. So at the max, we had about 150 patients occupying COVID beds. Our wave 2, which peaked in mid-November, was much, much greater. And you'll see from that graph that we had over 300 patients occupying beds. That's almost half our bed stock. And also really importantly, the bottom left-hand corner shows the impact on critical care, which you'll have heard about in the national news. So our regular numbers of critical care patients, so around 15 patients. So the left-hand side of the graph, and the green is the non-COVID patients and the red is the COVID patients. And you'll see that as of mid-November, we were almost double the number of critical care patients that we would normally have. So that all requires one-to-one nursing staffing. So the kind of impact on our staffing and availability to do other work was really profound during that period. And latterly, over the last few weeks, it's been about providing mutual aid to England and to ensure that the most urgent cancer and surgery patients from the surrounding organisations get treated, because very fortunately our January has not seen the third peak that we were planning for. The third graph on the bottom right hand corner just shows that close relationship, of course, between what we see in the community and what happens to our staff. So at the peak of COVID patients in the hospital, we also had the greatest number of staff absent for the same reason. So next slide, please, Nicola. So today I'm just going to talk a little bit about our preparations into wave one and the particular challenges and personal toll on people. I'm then going to talk about how we tried to restart non-COVID services, which has been hugely challenging. The planning and entry into wave two, which as I said, was a much different and much harder experience than wave one. Mad planning for a wave three, and we were really concerned about what the size that was going to be because of the residual numbers of patients still in the hospital from November, and now the focus, which is much more mutual aid and vaccinations. So really, I think I'll start the journey in mid-late March, when I was sat in a room with a large number of you can stop showing slides now, Nicola, thank you. I was sat in a room with a large number of senior doctors, and I think it was at this time where the kind of national picture was building, but we were seeing the images from Italy and starting to think this could be really real for the UK. But still, there was that kind of element of disbelief. So I had some intelligence from public health, which was telling us that we were going to have several hundred excess deaths a day at the peak of the pandemic. And I remember sharing this with some of our senior leaders in the organisation, and was met with some level of amusement. People could not believe that those figures were correct. And so I got the public health director on the phone who assured me that the worst case and the reasonable best case scenario that he'd given me was absolutely correct. And it changed the tone of the meeting and the preparations from that point instantly. So really at that period, it was full on preparations. We were working 7 days a week, racing against the clock really, and the tide of what we knew was coming, and we could see what was happening in London. We were probably 2 or 3 weeks behind that time scale, so I had a little bit more time to prepare. So lots of national guidance coming out about infection control management, about PPE, about testing, which of course we had very limited testing at that point. And also some major changes in our services. So overnight, our emergency department attendances dropped by 50%. And as well as all of the patients that perhaps don't need to come to AD, we also saw drops in patients with really serious complaints like heart attacks, like stroke. And that was really concerning, because clearly these weren't patients that weren't having those issues. We were really concerned about what was happening to these individuals in the community. So there was this eerie quietness really in late March for us. And I think at this point, we were still thinking, okay, this is going to be a really tough 12 weeks, but after that, we'll get back to normal and we'll recover the services and so on. And then all of a sudden it came. So the kind of preparations we were doing, there was firstly the technical stuff. So changing the hospital estate, reworking the organisation into infected flows for patients and non-infected areas for patients, putting up new walls. We reconfigured our entire ward block to bring the respiratory wards down the tower block, because the pressure of the oxygen was better there, and we anticipated that as a potential issue. We created protected areas for patients that had to come on site but were very vulnerable, so cancer patients receiving chemotherapy and so on. But this issue about the limited testing was a massive issue. So on a day-by-day basis, we had to prioritise which of our frontline staff would be tested for COVID and who wouldn't. So we had lots of people absent with symptoms or potential symptoms, but had such limited testing. That was a real huge challenge. We then had to also make huge service changes within a few days. And I think it was really heartening to see how dynamic and agile the NHS could be. It's an organisation that often gets criticised for being slow to change, but I saw things change overnight. Within a few days, we shifted outpatient attendances to about 40% video or telephone, something that we've been trying to do in the NHS for several years. Yeah. We set up drive-through services at local stadiums to keep people safe. And also consolidated services across our organisation. So rather than 2 maternity services, we put that onto one site in Doncaster. Similarly with orthopaedic trauma, we consolidated that because the challenges around our staffing profiles during COVID was really difficult to maintain 2 sites. I think the major preparation though was around people, and clearly what we were anticipating in terms of the level of demand required huge staff redeployment exercise and training. So we were training people up in additional respiratory skills, in critical care skills, getting everyone trained on the to make sure everyone had the safe masks, and redeploying staff on a scale that, you know, I've never experienced anything like really in my career. And just to give you a feel of what that meant for individuals is, you maybe your day job was working on routine surgery, routine day case surgery, like you know, small operations where you don't really come across much death, and some of those staff would be redeployed to critical care or to respiratory, where they'd be suddenly dealing with death, several deaths on a daily basis, and often without the support of the family to support those individual patients. So providing that personal support as well as that skilled support, training in the skilled support to the team. So an absolutely huge impact. And then also the preparations around setting up a level 4 incident room. So normally reserved for one-off incidents, you know, whether that's, you know, fire, some issue around state, or, you know, the terrorist attack in London I was involved in July 2007. But this was now setting up a similar arrangement that was going to last for months and months and months and months. So starting to think about how do you keep your leadership team energized and motivated and able to maintain that level of support 7 days a week for what was going to be months and months of challenge. So that was wave one, and then we started seeing we also lots of partnership working as well, so public health, local resilient forums, local government, to think about some of those really big challenging questions about excess deaths. How would we manage a level of death way beyond what our local populations are used to, and so some really challenging discussions around that, as well as, you know, massive decisions around investing in our local infrastructure. So we invested in doubling our critical care facility, and in, you know, and that was done within a matter of months with some support from national funding as well. So there was a huge effort and a huge sense of fear really about the size of the challenge that was to come. And I think really in that first wave, clearly there was a huge amount of information about PPE in the media, and there were some real challenges about PPE again, and some kinds of decisions I think that I never thought I would experience in having to be part of in the NHS in first world medicine really, and brought me back to some experience I had early in my career about working in Tanzania on the HIV and AIDS pandemic, and it was just a whole different context that we were working within. So we had our peak in mid-April at around 150 patients, which wasn't as challenging. From a capacity, we had enough capacity, so it was challenging for teams managing the infection control regimes, and so on was very challenging, but the numbers weren't quite as high as we expected. But of course, the personal toll on people and the deaths of the individuals that I mentioned, of staff as well as family and friends, took a huge toll on morale and impact throughout the organisation. And of course, that different way of operating without the support of visitors to patients, a whole different experience. And I think what I saw was of course the organisation really stepped up, but also the value and profile and of some of our most junior members of staff. So you know, healthcare assistants that have been redeployed to respiratory and and perhaps were the person, you know, well, I know there were family members who were hugely grateful for some of the actions that those healthcare assistants took in the final hours of their loved ones' lives, and also the cleaning assistants. The impact of their roles in the organisation was just absolutely brought to the fore, and we had staff, you know, cleaners working in our COVID areas for, you know, 11 hours a day for month after month after month, and just really taking value in that hugely important work. So I think what we realised through this time was the importance of psychological support, and the need to support certainly our most acute areas, but now much more generally right across the organisation, and how we deal with this as almost like a post-traumatic stress incident, and that's the kind of conversations that we're having now, and how we support wellbeing right through the organisation. So then wave one abated, and it got into the summer months, and we'd been pushed by the NHS England to restore non-COVID services, and with some challenging targets with financial penalties attached, and that was hugely challenging. And I think I hadn't planned that, I hadn't expected that, because it felt like we were just doing what we normally would do. So, and of course, this is the period where we've got Eat Out to Help Out, we've got internally in the organisation these growing backlogs of patients that have been waiting for often routine work, but also some treatment regimes have been put on hold for some quite urgent patients because it's not been safe to do that during the COVID pandemic. So that was hugely challenging, and restoring services in a way, you know, COVID safe ways, with staff often that were scared about delivering in this pandemic context. So that was really challenging. And then we went into autumn, and I can remember the meeting, for us this was early October, where our public health experts were telling us we had 6 weeks until the peak, and within a week we had our peak.
Yeah.
And this was much bigger, as the data shows, than we'd had first off. So some of the challenges had gone. So testing by this point wasn't a problem, so we could test everyone quickly, both patients and staff. PPE wasn't a problem, that was sorted, but also there was this pressure and need to do much more of our planned non-COVID work as well, and that was hugely challenging in terms of getting that balance right. But at one point, when Boris, I think at the end of October, made his announcement of the second national lockdown, our organisation had the second highest occupancy of any organisation. So Barnsley down the road from us had number one, we were number 2. So that was a really challenging position. So I think then we were worried and thinking January is going to be terrible, and we're planning for a much higher level of patients, and thinking about what are those with partners, what are those additional plans that we can deliver. Unfortunately for us, that hasn't quite arrived, and so now this has been on mutual aid to other organisations. And I think probably that's all I want to say. I think the final things really are just seeing the exhaustion of staff and how we recover from this as we start through and get the population vaccinated.
Yeah.
I'll leave it there.
Thank you very much indeed, Becky. Thank you. Aaron, over to you.
Thank you. I've just got some slides which I'll just share with you all. Hopefully you can see those okay.
Right.
So what I'm going to talk about is a little bit about my role in the hospital, a little bit about my role outside of the hospital, and some of the teaching that I do, and sort of some of the respiratory physiology that I teach, that certainly has been sort of productive. A lot more questions in the last couple of years about what happens when you put someone on a ventilator than students normally ask. So my clinical role is as an anaesthetic and intensive care doctor, usually at Addenbrooke's hospital, but for the pandemic I've been moved to Peterborough City Hospital, and that really has felt like being on the front line. It's been very involved clinical work, and I suppose the intensity of the work is something that is normally inherent in an intensive care job, but it has been really an order of magnitude greater than anything that I think anyone really on the front line was expecting. I've included this picture here. I wanted, I suppose, on the left to include a picture of me in all of the PPE, but I actually became unrecognisable. So there's some evidence that perhaps it wasn't me underneath there. That there are additional masks over the top that you wear in order to keep the sort of aerosol away from your eyes, which is another mode of transmission. And then on top of that, there are gowns on top that sort of keep your scrubs free from COVID. So the clinical role has been intense. And then a little bit about the sort of legal and ethical role that I've played. Normally, I'm an advisor for the Legal and Ethical Advisory Group for the Intensive Care Society. So we're responsible for helping to develop guidelines that are useful to guide intensive care clinicians in the ethics and law of their practice. And I also do some sort of educational work for NHS resolutions, where we run seminars that are targeted at trying to really reduce the liability burden of NHS practice. So trying to minimise the amount of effectively claims that are made against the NHS, or making sure that we learn the maximum amount from the claims that we get. So the Intensive Care Society work, I think, has been the source of most of the interesting sort of ethical component of what I've been doing over the last 12 months. It's based in this lovely building in London, which actually, due to the travel restrictions, I've sort of been heavily involved in their work, but not actually managed to see for the last 12 months. It's based in the Royal College of Anaesthetists, and that's really highlights, I suppose, the close relationship between the specialties of anaesthesia and intensive care. And I joined this group 2 years ago now, and we had what in retrospect I think is really quite a quaint program of sort of guidance that we wanted to put out. This was before sort of COVID had come along, and we had various ideas about projects that we wanted to do, and really COVID sort of took this all by storm and completely changed what we were planning and what we foresaw would be needed. And what we saw very early on was this need for triage decisions to be made, and that certainly made the headlines on a number of newspapers, and certainly seemed to spark the interest both of the general public in their concern about how these kind of triage decisions could be made. You know, am I going to be discounted right from the very beginning because I've got a health condition? But also it sparks the interest, as you can imagine, of lawyers who were wondering about the legality of whichever guidelines we might put out or whichever triage decisions might be made, but also the legality of the procedural way in which those decisions are made. There was some discussion early on about a three wise men committee, or a three wise person committee, and the legality of that, and exactly the framework that they were using to make triage decisions. So certainly one of the issues that I think we did quite well to foresee was this need to be able to decide in very difficult circumstances how to allocate the resources, primarily of intensive care, because it was the Intensive Care Society, to patients to achieve the best possible outcome with the resources that we had. So to match up, I suppose, the patients that would best benefit from the interventions that we had with the sort of resources that we had. What I think we didn't do so well to foresee were really all of the practical aspects of working in COVID-dominated units. And some of I think the guidelines that have been most challenging are the ones that I've sort of got on the next couple of slides, have been issues that we didn't really foresee, and issues which I think there has been a lot of debate about how we manage, and certainly the video conferencing guidelines, which I was involved with, where we try and come up with a framework for the effective use of video conferencing, both this is from an intensive care perspective, to discuss with relatives and try and maintain that healthy interaction, to explain to relatives what's happening with their loved one when they're admitted to intensive care, but also being able to use video conferencing in the sort of recovery phase for intensive care patients, so allowing them to interact with relatives in a way that actually is very helpful and therapeutic. And the other sort of guideline, which I think we didn't foresee sufficiently, was the idea of having to move patients between different trusts, and I think there is an idea in emergency planning that trusts will provide some mutual aid. And I think what we hadn't necessarily thought through, and perhaps still don't have a really solid framework for, is the ethics of decision making, where you're deciding which patient to move from a very stressed trust and which trust to move them to. And this is something which intensive care is extremely involved with, because of course we're responsible for running these transfers. So, you know, last night I was in the back of an ambulance and I was going from one trust to another. So we run these transfers, but it was a slightly different dimension to just how we're going to do the transfer. It was how we pick the patient, because what we want to do is we want to have an intervention. This is the transfer. That sort of matches the normal way in which we treat patients, which is to treat them in their interests and to do things which are for their good. And actually moving patients around in order to relieve the pressure on an intensive care unit is a slightly different paradigm to what we're used to, because really the benefit perhaps can fall to the patient, perhaps it will fall to other patients, but actually also it falls in many ways to the workload of staff, and it falls also to future patients who are yet to be admitted to the very stressed unit. So being able to rationalize those decisions and have a framework for making those decisions was really important, and I suspect we've really come onto this issue very late. That being said, actually, if you look internationally, so I think the most advanced sort of triage type protocols that have been written were really from North America, and Canada and New York had protocols which actually we were quite keen, certainly in the east of England, to base our protocols on. Even they, with their foresight, I suppose, from the earlier epidemics in sort of 2007, 2010, they actually struggled with the implementation. So these ethical frameworks are something which I think it's very easy to think of in advance and to build in advance, and then you actually come across the difficult cases and the multiple challenges from multiple different dimensions with you know, multidisciplinary team decisions and patients that are sort of, you know, very emotionally invested, relatives that are very emotionally invested. These are very fraught decisions, and actually a framework that existed for a previous time really won't necessarily do well. So this is a sort of summary of the guidelines I'm going to talk about. I'll talk about the ethical one, the ethics of transfer first. So this is a statement which effectively tries to give a framework for how we decide which patients are going to move between one unit and another. And these sorts of decisions, as I said, that it's challenging because it really takes us away from the way that we normally look at sort of treatments. Transferring patients involves risk, and I think this was something that the intensive care community had understood, but perhaps we'd had sort of difficulty with the sort of the wider trust community in understanding that if we move a patient from A to B, it may provide benefits for A, it may even provide benefits for B, depending on why we're doing it and who's providing the specialist care. But there is a particular and sort of inescapable risk for that patient, and that was something that we were really seeing firsthand, because when you move a patient, they are away from all of the other sources of advice, they're away from all of the other investigations that you could do. They are, I mean, we try not to do this, but they're sometimes moved late at night, or in circumstances where actually the preparation time is limited. And these are very real risks, and they're inescapable risks. And so I suppose the idea that what we do to patients ought to be in their interest is matched really with the idea that we shouldn't be doing harm. And this was something that I think we struggled with conceptually in the first wave, and we're struggling with practically still now. How do we distribute intensive care patients so that they can get the most of the resources, but in the process of allocating people to where those resources are, we don't in fact cause more harm than we're trying to avoid? One of the ways that we've tried to create these frameworks is really to look at what clinicians were worried about and what relatives were worried about, and relatives and patients were worried about. And the key concern for patients is, am I going to be disadvantaged? Is my care going to be disadvantaged by being moved? And of course, we have to be very honest, and we have to explain that actually every time a patient is moved, there is a sort of a loss of some of the continuity, however hard we try to maintain it. And another source, I suppose, of criticism of any transfer policy is from relatives who are worried that their sort of relative who's a patient is going to be moved and their care is going to suffer. And actually, we got a lot of criticism from relatives of the way in which these decisions are made. And so what we've tried to do is to try to take some of those factors into account and come up with a way of sort of organizing and introducing these transfers so that we address some of the concerns of the relatives, the concerns of patients, concerns of staff as well. And I suppose the other issue with transfers is always that when we move a patient from A to B, we're usually trying to do that in some way to provide a benefit to the transferred patient so that we meet this general sort of idea of providing a benefit. But this also requires a degree of foresight that we've not always had. So the receiving unit, we would hope, we would assume and we'd plan that they would be less stressed. And so we could honestly say to the patient that we move, we are moving you to a unit that is under less stress. Now, that might be true at the time that we move the patient, and it may not be true a few weeks down the line. And Rebecca has spoken already about how quickly the situation has changed. And we've really had to be very frank and have some very sort of honest discussions with patients about what we're doing and how we're doing it. And all of this has been on a background, actually, of patients who are already critically unwell and have their own care needs, which are complex, even if we weren't going to move them between trusts. The other thing I'm going to talk a little bit about is video conferencing, because I think this is something which there has been, I mean, again, this is something Rebecca's already mentioned, there's been a desperate need for the use of this already, largely in an outpatient setting. What we've tried to do with our guidelines is provide a framework for using video conferencing in intensive care. Normally, just to give you an idea of the kind of interactions that we would have face-to-face, patients would, of course, when they come into the emergency department, usually be accompanied by their relatives, and this would provide for intensive care a really useful sort of resource of information, so that we can address both the patient's concerns about what's going to happen to them, but also the relatives who, not suffering from the illness, are able to sort of scrutinize our decisions, are able to ask researching questions, and are able to advocate, if you like, for their relative. Now, those interactions are extremely valuable for us in intensive care, and it's something that's really impaired in the current pandemic, because patients are coming into the emergency department and they're not accompanied by relatives, and of course there are good reasons for this, but it does make our search for information about what the patient really would want, if they're not able to tell this to us, really an order of magnitude harder. If you think of the kind of information that we would want to get, what we're really interested in is if the patient were to become unconscious, what kind of treatments would they be willing to have, what kind of quality of life would they be willing to accept, so that we can get an idea, given the resources that are available to us, how best we should employ them for the benefit of this patient. Now, that conversation works actually really well, and we've got a considerable experience having these conversations face-to-face. If you imagine how these conversations are going to happen over the phone, without that face-to-face component, there is an inherent distrust, especially in a pandemic, for an intensive care doctor asking, would your relative really want this? Because the inference that patients have made, and I suspect it's a reasonable one given the circumstances, is, are you trying to convince me to say that my relative would not want X, Y, and Z treatment? And so video conferencing has really had a kind of unanticipated benefit here, because that face-to-face communication has just been invaluable in allowing relatives to see what we're doing, to see us, to see who's treating their relative, and to allow us to explain in a much more natural way what we're planning to do, what the options are, and really allow them to interact in a way that I think is more natural. The other sort of aspect where video conferencing has just been invaluable is actually for allowing patients to interact with their relatives at home, and this presents a particular difficulty in intensive care, because the patients are often next to other critically unwell patients, and you could imagine with a patient who's able to use a mobile phone, the possibility of inappropriate disclosure of information from other patients who are also in the same bay. Now, these are problems that perhaps ought to, or perhaps could be circumvented by putting patients in individual rooms, and that in itself has its own logistical problems with staffing ratios. And so video conferencing frameworks have really allowed us to provide staff who may not have very much experience with using sort of teleconferencing or sort of Zoom style meetings, to allow nurses to come up with I suppose a set of instructions which allow them to set things up in a way that allows the patient to get that benefit from interaction with their relatives without these inappropriate disclosures. The other area which has proved particularly controversial with video conferencing, and where there seems to be, in a way that I've found very unusual, a split between what patients want and what their relatives want. This idea that when a patient is unconscious, it may be possible to provide the relatives with a picture of them or a video of them, so that the relatives can see their progress, so that they can understand what's happening to them. Now, from an intensive care perspective, there is actually a particular value in that for us, because what we want from the relatives is an idea of what indirectly the patient would want. And in order to help the relatives to make that decision, they often do need to understand what the patient is going through, and they're best placed to know the patient and understand what they would want. But they kind of need that insight into what we're doing at the moment. However, and relatives, sorry,
can I ask you to give me like 1 more minute, because otherwise we're not going to get any questions in from.
Oh yeah, sorry, of course.
Yeah.
So, and I suppose the other dimension of this is that patients have often expressed really quite significant concerns about being videoed when they're unconscious,
Yeah.
and really this is a line that we've had to walk by asking for as much information in advance as possible about what people would want, and also setting up these calls to disclose as little as possible to kind of get what we want out of the call, and for allow the relatives to get what they want as well. So perhaps I could sort of leave it there with those 2 sets of guidelines, and then we can move on to questions.
Brilliant. Thank you. Listen, it's perfectly obvious we could have done this. We could have done a very, very long stint with you, Tim. We may have to get you back, I think, for a discussion about the aftermath and the next stage, because I certainly know from my experience that the thing that in some ways I'm most worried about is, and you both know this far better than me, is that people have now done a year of this. With very little break, and the expectation there'd be a sort of decent break between COVID-1 and COVID-2 that didn't happen, and an expectation, I think, from government, media, patients too, that as we exit this part of COVID, we can ramp up operations when the staff are so exhausted they're almost falling over. And I think that's one of the things I think that would be interesting to ask you both, from my point of view, is how can we communicate in a proper way with the public about the real impact of this on the NHS and on staff, so that people have a level of understanding about the total exhaustion, I think, that people have reached, and so that people understand there has to be some time for people to rebuild before they tackle the waiting lists. Becky, I mean, it must be on your plate.
Yeah, I mean, it's hugely challenging, because I think what's keeping me awake at night at the moment is those backlogs, actually. And I've just been doing a lot of work recently to understand the number of patients waiting for all of our different treatments, and understand the different urgency, and, you know, think about how we ever recover that. And it feels like I've gone back at least 20 years in my career when patients waited a lot longer for treatment. And this is worse than, you know, much worse than that. So it's hugely concerning, because, of course, within that massive population, whilst we've done our best to stratify that and to ensure that it's clinically, we know that there will be some patients that we don't quite understand the diagnosis of yet. So there is risk in that. But equally, I think if we don't give our staff time and space to rebuild and to recoup, then I think we'll feel that for years and years to come. So I think it's probably about trying to communicate some of the reality of what our staff have been through. And I think it's hard to really appreciate that. It's hard for me to appreciate the experience of some of our real frontline staff. So I think we need to get that across to the public.
Oh, thank you. Aaron, have you got anything to add on that? Another one, and in addition, can you also say how have you dealt with relatives who possibly haven't wanted patients removed as well?
Yeah, so I think in terms of, I suppose, publicising the degree of stress that the NHS has been under, and the need perhaps for a break, I'd say there seems to be a reasonable understanding, and I've seen a few articles which really talk from an NHS worker's perspective about how difficult it's been, and I think what's missing really is the link between that and the public's expectation for the resumption of normal service, because I think there is an appreciation of how hard we've worked, but that the next step really needs to be taken of explaining that there are impacts on normal services, and the two are not unrelated.
And it's that thing when adrenaline stops as well, isn't it? I mean, that's because everybody I talk to who's engaged in the NHS, they're sort of driven, and they're all working crazy hours, and they have been doing for ages, and they're keeping going. But you know that there's going to be a point at which that stops, and I just wonder how they'll be the next day in some ways.
Yes. With respect to what we do when relatives refuse, I mean, that really is the question, the sort of key question, because often patients are unconscious, and relatives are, I feel, the best advocates for what the patient really would want. And actually, what we've really tried to do is to understand the intervention that we have from the perspective of a treatment. So these transfers, when we explain them to relatives, we really emphasize that we are taking this patient from a place which is stretched, and we are trying to put them in a place which is less stressed, and this has an intrinsic benefit. And so I suppose if there are additional benefits for the unit that is sending the patient, and additional benefits for the other patients in that unit, that's really only part of the reason that we're doing this. And we've had also to be very careful in which patients we pick, because what we've tried to do is balance the benefit with also the risk to the patient. And the relatives are often quite understanding when we explain that actually certain patients, if they're transferred, there really is a minimal risk for the transfer depending on the severity of their illness, but really a potentially significant benefit at the other end if there is a specialist service that's available that's not available at the trust that they're in at the moment. So we've tried to arrange transfers.
How have you both, because you both must have been dealing with this, how have you dealt with a different form of ethics, which is dealing with relatives where actually you've had to tell them that their loved ones are not going to benefit from either the critical care bed, or it's certainly in the Brompton and Harefield, we have 28 ECMO beds now, we used to have 5, but that's a really big decision point. And how do you deal with, or how do your colleagues deal with conversations about who isn't getting that care?
So I think one of the advantages that we've had in this country is that we do have a good background in understanding that the availability of a treatment does not dictate that the treatment is provided. What we do is what we don't do is match people with any treatment that's available that might potentially provide any benefit at all. What we do is we try and match the treatments with what will really help. And what this means is we actually have considerable experience in explaining to people when a treatment won't help, that we're not going to offer it. And that actually has been a bit of a savior in this pandemic, because often when we see that a patient is not going to benefit, we actually have experience in having those kinds of conversations already. And what we're really doing is not saying that we don't want to provide this resource because we don't have it. A lot of the time we're saying that actually your relative is so unwell that we don't think this resource is going to help, and so it's not on the menu, the list of options that we're going to provide. And I think other countries have really struggled where they have a culture of providing because it's available, of a particular balance, and it's an acceptable balance to have, but it's different to what we have, of the length of life versus the quality of life. And you know, those kind of debates have really informed the way that we have these discussions.
And Becky, can I ask you a question about staff particularly? We've got a range of questions here. So we know there's a shortage of mental health services. We know there's PSDD in staff. We also know that there's a whole range of psychological support needed. To what extent are your hospitals able to deliver that? And what do you think you'll be able to deliver going forward to people? And are people prepared to access it? I mean, are they prepared to acknowledge they need it?
So I think we've done quite a lot of work with our teams that are most acutely affected. So the critical care and respiratory team, in terms of giving them access to psychological counselling, post-traumatic stress disorder care. But I think what we're understanding now is just the level of support we need to provide to all staff, really. So to a less intense level, Schwartz rounds and the equivalent for kind of emotional health and well-being, we're trying to establish groups and reflection points for staff right across the organisation. And I think it's that widespread low to moderate support that is the particular area that we've not fully addressed, but we absolutely need to. And that's a real concern. And unfortunately, you know, we will lose some staff that decide that they don't want to continue their clinical roles anymore. And we've seen, you know, we've had 3 deaths, but we've also had a number of staff that have ended up on intensive care and survived, but are just, you know, obviously very scarred. Yeah.
Big broad question for both of you. I'm sure you'll answer in different ways. What lessons do you think the system or your particular hospitals or you have learned through the last year? And what should be learned if it hasn't been so far by any part of the system, centre, government, NHS England, whatever, wherever you want to go on that big broad question?
So I think from a system perspective, so you'll know the kind of policy direction of travel is integrated working, greater collaboration across mental health, physical health, local government, voluntary sector, etc. And I think what I've seen is that that's been absolutely turbocharged through the last year. So the absolute importance of those links and integrated working and interdependence has been, you know, phenomenal, really. And that's actually been hugely facilitated by video conferencing, because it's just so easier to meet with colleagues around the system. So I think we'll see a turbocharging of that. I think within the organisation, what's been interesting is the management of the pandemic has further exposed to me the strengths and the weaknesses of the organisation that we knew before. And so the areas that I wanted to focus on before we started this have just, you know, exacerbated in either strength or areas of development, and also the quality and importance of leadership at all levels through the organisation is also crucial. We have a big focus this year, which we needed to do before COVID as well, on lots of leadership development, both people skills and the technical skills to lead, and that feels an absolute importance.
Yeah.
And I'll come back to you on the government question.
Fine. I'll come back to
I think in terms of what intensive care can learn, I think the continual refocusing on the importance of the patient at the centre of all of this, because there are so many sort of countermanding pressures and so many directions in which you're pulled as you work, and I think being able to continuously refocus on the patient that you're treating and the patient group that we're treating is really the most important thing. And the kind of ethical guidelines really are there to make sure that we continue to be able to do that. And whilst you're called in every different direction and being asked to do 100 different things, making sure that you really do look after the people that are in your charge, I think has really been what the focus of this has all been about.
Okay. Can I ask you another sort of bucket of questions, I suppose, which is about equality of resources and equality of distribution of resources? And have you got any views on anything you've seen that's been fair or unfair, either geographically or between types of health service, or I guess also within communities? So background, or effects on BAME community, or whatever. I mean, what do you think there's lessons that we can learn around on the sort of broad equality agenda?
I think one of the groups that I think has been particularly underserved, and I suspect it's in the case normally, but in the pandemic especially, have been people who do not have an advocate who is not unwell.
Yeah. Because
one of the most useful things for keeping track of someone's care and the multitude of background conditions that someone comes with is actually someone else that knows you. And if you have a supportive family and they are aware of your conditions and they're aware of what you need, they're very effective advocates. And as much as we would want to be able to pull that information out and be able to use it for a patient's benefit, we don't know the patient before they come. And actually, the lack of that support, I think, has been a double disadvantage. It's associated with all sorts of other health disadvantages before you even get COVID. But once you get COVID, thinking of how long the recovery period is and the support that you'll need there, I think that is a group that is particularly disadvantaged, the only effectively.
Yeah. That's really interesting. Becky.
Yeah, I think clearly the kind of health inequalities that the pandemic has revealed have just been really stark, and we know that, we knew this before, that our country is hugely divided in terms of health outcomes, deprivation, and this pandemic has shown that in the impact on different communities and from deprived backgrounds, BAME backgrounds, etc. And actually we've seen that even amongst our own staff. So in terms of who's got sick, we've seen that in terms of the vaccine take up amongst our frontline staff varies by background, and that's that some of that is really, really concerning, and something I think gives us a lot of food for thought about our direction and culture and policies as a country and where we want to be. I think the other interesting question really when we think about how we manage the pandemic is the kind of relative, and it's a really difficult set of questions, but the relative balance of priority we've made about managing COVID, this acutely non-elective emergency disease, versus all of those other really urgent things that take place. So we have treated the most urgent cancers but actually our cancer treatment has been affected by COVID, and have we got that balance right? I think it's a really difficult question to answer, and I don't know what the answer is, but I think there's a debate to be had, I think.
Thank you.
There is a question about advanced decisions.
I was just going to ask you that one.
Yeah, I mean, I don't think there have been enough advanced decisions. I think it's such a satisfying document to find, because what it says, it's a statement which says that the patient does not want certain treatments in certain circumstances. And the reason I'm so happy to see that is not because it reduces the workload of whomever is looking after that patient, is because a lot of the things that we do, and I think this is where a lot of the psychological burden on staff comes from, really are quite torturous therapies. And I don't think there's much of another way to describe it. If you've seen sort of the sort of media portrayals of intensive care, the reality of that, with the tight-fitting masks, the fact that patients often, in order for the mask to work, don't have access to sort of water to drink, so we have to sort of give the water through a nasogastric tube, and that makes them very uncomfortable, and they have to often adopt very unusual positions so that we can oxygenate different parts of the lung. It's very noisy, they're sleep deprived. The whole package of what we do is unfortunately torturous, in addition to being in the long-term interests of their health. And seeing that is stressful, and experiencing that as a patient, I'm sure, is extremely stressful. And what an advanced decision does is it means that if you've had the good fortune to have thought about this in advance, and you don't think that you would want to endure that kind of therapy, that you can make that known at the earliest opportunity, so that we don't do it to you. Because it's bad enough, I think, exposing people to these sorts of therapies which are extreme, without subsequently finding out that they wouldn't have wanted it. That's just an additional stress and an additional torture.
How good is the data that you've got? I mean, you've both shared data with us, and clearly there's data at times has been patchy, and across the NHS it's been some trusts are clearly much stronger at dealing with data and performance than others. Has this been a bit of a rocket booster as well for improving measurement of performance? And I mean, Becky, where are you on that?
We've spent a huge amount of time getting the metrics right for COVID, managing the pandemic, and it has been absolutely crucial. And we've had to set up new ways of collecting data and new ways of reporting that. And I think we're into a rhythm now, but it took us some while to get that right. And still, some of the metrics aren't as transparent and visible to us that need to be, that are part of our kind of core data set of managing that. I think in the first wave it was really, really difficult, because things like the testing regimes and so on weren't there. So actually having good data around that was really challenging. So I think it has improved, but I would say that I think nationally we've done it in a fairly NHS based way, which is there's been lots of national directives. We've had to provide lots of information to the centre. We've established what we need locally to manage this. But so I think it has again shown up the strengths and weaknesses in how we collect data, and there's certainly lots more that our organisation needs to do on this.
Yeah, there was a question about do you use any agile frameworks to help?
Agile frameworks. I'm wondering what kind of examples people are thinking of, which probably means no.
Yeah, probably. Chris, you'll have to put something in chat to explain that to us all. Aaron, can I ask you a question about training and of both medical students now, and to what extent have they suffered or have they gained in any way? And generally, how is the medical profession feeling, I suppose?
I think postgraduate training, so this is for doctors after they've graduated, but before they become a consultant, really has suffered, especially for specialties where a lot of their routine work has been cancelled. And I really do feel for my surgical colleagues, at least, so I sort of wear an anaesthetic hat and an intensive care hat, and my anaesthetic hat has turned out to be very useful in intensive care. But for the surgeons who would normally be on the other side of the drapes operating when I'm an anaesthetist, there actually hasn't been a lot of work for them to do. And for a consultant that is frustrating, but for a trainee, that's potentially devastating for their training and their career. As for medical students, I'm involved in sort of teaching medical students at Fitz, and I think we have tried extremely hard to make their experience as positive as possible. They've gained and they've lost. They've lost in the sense that we always hoped to provide that community, that sort of academic community, and it's a community that I think is better provided in person than remotely, as much as we can try and improve that experience. But they've gained, I think, as well, because there is a renewed, I think, enthusiasm for exactly what they're embarking on. You know, they are interested. You know, the students that are studying physiology are interested in what happens when you intubate someone. You know, what goes on when you put them on a ventilator? How does sedation work? You know, what does it mean when you put the patient to sleep? These are questions which derive really from the basic sciences that we teach in the first and the second year. So they've gained, I think, in really understanding where they're going in a way that perhaps medical students haven't necessarily before. But I think perhaps we all recognise that the in-person experience is what we would really hoped to provide, and we can get as close as we can, but we can't perhaps completely emulate it.
I mean, I think what's interesting is that the interest in people going into medicine and medical careers and health careers in general is very high. So it's certainly raised an awareness, I think, of the range of jobs and the importance of the jobs, I think, across the piece. I mean, Becky, bit of a mean one. You know, if you were sitting here with a load of Fitz students, not just medical students, but across the piece, would you say, you obviously did the NHS management training, I think, yes, quite a while ago. What would you say to them? Yes or no?
Oh, absolutely, yes. Yeah, I think what's fantastic about the NHS is compared to other industries is that actually we genuinely, when you ask people about why they do it, what they're motivated for, there is this real shared purpose about, you know, it's about one person caring for another, really, and does genuinely motivate people right through the ranks. And I think from my perspective, I've always hugely enjoyed working with all the different professional groups. It's always been a really stimulating environment to work in. I'm always learning. And that's, you know, that's great. And working with people motivated by the same values. So yeah, absolutely, I'd thoroughly recommend it. And whilst this last year has been obviously hugely tough, never have I regretted being in the role or in the NHS. And I think more than ever, it's shown the importance of the central health system and a care system that's free at the point of delivery.
And Aaron, from you, I mean, to what extent, I suppose I'm interested, to what extent you think it's also pulled the team together in a broad sense, in a probably because people have probably worked together who haven't in the past, I would guess.
Yes, I think I have a much greater understanding of some of the other specialties simply because they've been drafted into intensive care and we've ended up working together, and certainly I've got a greater appreciation of the skills and the transferability of the skills that other sort of clinical professional groups have. And I think what's been really invaluable has been the understanding for the general clinical professional population of how intensive care works, because yes, we're a specialty which is under pressure all of the time. It's particular pressure now, but we're always under pressure. And I think the pressure is lessened by working with colleagues who really understand the flow of our work and what we're trying to do. And perhaps being able to integrate some of what we would normally do into their own practice and sort of trying to share the burden a little bit. And I think that interprofessional working is thrown together as we have been, but because of the pandemic, actually has opened up our eyes to people who are only working, you know, down the corridor in the hospital, but whom I otherwise, you know, wouldn't normally see. Intensive care doctors don't normally see ophthalmologists, but I've, you know, seen lots of ophthalmologists recently working with me in intensive care.
Yeah. Final question, because I know Becky's still at work and Aaron's about to go to work. So final question to both of you. I suspect you've probably not had time to pore over the white paper today, but what you've seen of the headlines of it, do you broadly welcome it? Are there things that you wish were there that aren't there? I mean, what are the things that we ought to be concentrating on, I guess, going forwards, partly as that goes through and can be improved before it becomes legislation? Aaron, let me start with you.
So I think this presumably is the white paper about the competition within the NHS and trying to
integrated care systems. Yeah.
So I think the integration is absolutely vital, and I'm constantly met with patients who are absolutely astounded that we can't get information from their GP and we don't have access to information from their sort of psychiatric service. And this really is something which should have been fixed many years ago. And if this integration hopefully gets us closer to that and actually working more closely with colleagues, we're all looking after the same patients, then I welcome it. I'm not great at predicting how a white paper gets translated into practice, but if it does that, I'd be happy.
Fine. And you, Becky?
Yeah, so fully support the direction of travel actually in terms of greater integrated collaborative working and this greater prevention focus. I think though the reality of delivering that, we're some way off, and I'm not sure that we've still got the right levers to work across local government and the NHS in particular. And really, if we're really serious about the prevention agenda, really we need to be putting resources upstream. So from what we both do at the kind of acute end to actually the stuff that encourages healthier lifestyles and addresses some of those big health inequalities that we know are endemic in our society.
We're going to have to stop because we've got to let you both go, but thank you very much indeed. I always say thank you when we finish a session, but there's a different sort of thank you to you two, because thank you for everything you've done for last year and are going to have to keep doing. So I think everybody who's joined us tonight will feel a particularly sort of big thanks to you and to your colleagues. So thank you very much indeed. And I threaten to bring you back because it'd be really interesting. It'd be really interesting sort of 6-9 months from now, actually, to see how you've coped with the aftermath and how your teams are feeling, I think. So we may just persuade you to come back and do another hour with us if you're willing to do so in the future. But for now, thank you very much indeed. Thanks very much.
Thank you.
Thank you.
Thanks.